Good afternoon, everyone. Moving on to case number 5. This was a 70-year-old male who presented with a gradually increasing swelling on the posterior aspect of the right side of the neck for a period of 4 years. On ultrasonography, it was a well-defined lobulated homogeneous mass with few hypoechoic areas and was located in the subcutaneous plane. CT was suggestive of a hemangioma with no deeper extension. On CT scan, there was this well-defined lesion which was located in the subcutaneous plane, and it showed heterogeneity on contrast. En bloc excision of the mass was done, and we received a skin-covered lobulated mass which was firm, grayish-white with mucoid areas. Dr. Lubna from Topiwala National Medical College to please discuss the case.
Hello, am I audible, ma'am?
Yeah. We provided you with 2 H&E stained digitalized images, and I will be showing you 8 images on the HE stained images. Please start.
Yes, ma'am. In this section, we can see tumor mass in which the cells are spindle shaped, which are arranged in interlacing fascicles and at some places in storiform pattern. And we can also see a myxoid background. Next slide.
This is a high power view of the same.
Yeah. In this slide, we can see nuclei, spindle-shaped cells with elongated nuclei and scanty to moderate amount of eosinophilic cytoplasm.
And some amount of pleomorphism.
Yeah, and we can see pleomorphic nuclei, large hyperchromatic nuclei.
Yeah.
Next slide.
This is the next section.
Yeah, in this section, we can see the arrangement of tumor cells in interlacing fascicles and bundles, giving a herringbone appearance. And we can also see a multinucleated giant cell in this section.
Higher power view of the same.
Yeah, in this higher power view, we can see the nuclear pleomorphism, hyperchromasia, and also we can see interspersed lymphocytes in between the tumor cells. We can see typical
Numerous
mitosis.
mitotic figures, yeah.
Here
So
we
this
can
is
see an area of central geographic necrosis. So based on the histomorphological findings, we came to the diagnosis of undifferentiated spindle cell sarcoma. And we also ran few panel of IHC markers in which vimentin came strongly and diffusely positive, and S100, SMA, and CD68 were focally positive, and desmin was negative. Considering the histomorphology, clinical findings, and IHC findings, we came to conclusion that the diagnosis is undifferentiated spindle cell sarcoma. But we can also keep myxofibrosarcoma as diagnosis because the tumor cells show a large abundant area, myxoid area, curvilinear arrangement of vessels.
okay. So that was a very nice description, Dr. Lubna.
Thank you, ma'am.
Any other opinion of the house? Lubna was correct in her description and the diagnosis in which at which she has arrived. Recapitulating the case, we had this tumor with both hypocellular and hypercellular areas. The hypercellular areas were predominant as compared to the hypocellular areas. And this slide which we have provided, that was the only slide showing some myxoid change. Otherwise, there was very little myxoid change, and it was predominantly hypercellular. And we have these tumor cells which were very pleomorphic, long fascicular arrangement at places. In the hypocellular areas, a storiform pattern could also be identified, and pleomorphism, then tumor giant cells, mitotic figures, and necrosis. So we considered that this is a high-grade sarcoma, and we put in the following differentials: the leiomyosarcoma, undifferentiated pleomorphic sarcoma, an MPNST, a myofibroblastic sarcoma, and a rhabdomyosarcoma. Looking at the microscopy, we did not identify any cells, large cells, which remind us of a rhabdomyoblast. And also, there were no areas showing wavy nuclei with any peripheral nerve close to the tumor. So we ruled out the diagnosis of an MPNST and a rhabdomyosarcoma on H&E. We also ran some immunomarkers. Vimentin was positive. SMA was also positive, and this SMA showed diffuse cytoplasmic block positivity. S100, desmin, and myogenin were negative in our case. We did not find any focal positivity. So we ruled out this MPNST and RMS on histopathology also, and we did not get an S100 positive, and myogenin was also negative in our case. So we were left with a leiomyosarcoma, an undifferentiated pleomorphic sarcoma, and a myofibroblastic sarcoma. Now, vimentin and smooth muscle actin, they can be positive as well as they can be variable in these three tumors. However, because the SMA was diffusely cytoplasmic positive with block positivity, as compared to the tram-track appearance, which is seen in an undifferentiated pleomorphic sarcoma and a myofibroblastic sarcoma, we would like to call this as a leiomyosarcoma. And we would like to label this as a superficial leiomyosarcoma of the neck because of its superficial location and because of its rare presentation in the neck. The head neck is a rare presentation for a leiomyosarcoma, and if it occurs in the head neck location, it is usually the oral cavity or the sinonasal tract, and not on the subcutaneous areas of the neck. And because of this rarity, it can be associated with delayed diagnosis or a misdiagnosis. However, in our case, on clinical and as well as radiologically, it was diagnosed as a hemangioma. However, we would still like to do some further immunomarkers and cytogenetic studies which will clinch the diagnosis in this case. Thank you.